Welcome to The Explainer. Today, we're diving straight into a medical mystery that completely shook the foundations of global public health. We're going to explore how a single, massive anomaly in a monumental trial out of India ended up upending 40 years of established scientific consensus. It's an incredible story about methodology, the illusion of certainty, and what actually happens when the real world changes faster than our science can keep up with. To really grasp the sheer scale of this mystery, we have to drop right into the dusty plains of Uttar Pradesh, India, back in 2007. A team of researchers had just quietly finished collecting data for what was called the DEVTA trial, and the scale of this thing, absolutely staggering. They enrolled 1 million children. I mean, let that sink in for a second. 1 million kids. It was, and honestly still remains, the largest randomized trial in the history of medicine. It had its own massive bureaucracy, complex logistics chains, an entire army of health workers. But, as you'll see, it was the results of this monumental effort that would soon ignite a massive controversy. When the results eventually surfaced, they didn't just challenge a global policy. They kicked off a ferocious scientific civil war. The entire global nutrition community basically split right down the middle, pitting legendary researchers at Oxford against heavyweights at Johns Hopkins University. And the emotional stakes? Incredibly high. Accusations were literally flying back and forth about data suppression and methodological cowardice. One prominent researcher even claimed the opposing side was killing children through inaction. No way around it, this got ugly. So to understand how a simple vitamin capsule could cause such explosive conflict, we really have to go back to the beginning. Chapter 1. The Magic Bullet. Let's rewind a bit to the early 1980s in Aceh, Indonesia. An American ophthalmologist named Alfred Summer made a truly shocking discovery. Children with even mild vitamin A deficiency weren't just going blind at higher rates, they were dying at substantially higher rates. This observation kicked off a series of global trials, and eventually a landmark 1993 meta-analysis found something seemingly miraculous. Giving kids 2 cheap vitamin A capsules a year reduced all-cause child mortality by a staggering 23%. This wasn't just a marginal win, this was a public health magic bullet. Naturally, the WHO and UNICEF fully embraced it, and mass supplementation campaigns spread like wildfire across the globe. But here is the crucial catch. Now, what's really interesting about this is that the 23% drop in mortality wasn't some universal, unchangeable property of vitamin A itself. Epidemiologists call this effect modification by context. Think of it kind of like watering a houseplant. You're only going to see explosive, rapid growth if the plant was severely dehydrated in the first place, right? That 23% reduction happens when you give vitamin A to severely deficient children in populations with incredibly high baseline mortality, way before widespread measles vaccinations and before everyday cooking oil was fortified with vitamins. And this brilliantly illustrates the core issue. Notice the stark contrast between these two eras. By the early 2000s, the world had fundamentally changed. Measles vaccines were scaling up everywhere, massive economic growth was lifting millions out of extreme poverty, and food was increasingly fortified. So a new generation of researchers started asking a very logical question. If the baseline context has shifted this dramatically, does the intervention still work the exact same way it did in 1986? Chapter 2, The Million-Child Trial. Okay, let's dive into this next phase. To test if this magic bullet still held its power in a changing world, legendary Oxford biostatistician Richard Peto and researcher Shali Awasthi launched DEVTA. The trial kicked off in 1999. Data collection wrapped up in 2004, and then crickets. Nothing. A bizarre 14-year gap from start to publication. Look, in the fast-moving world of global health, 14 years is practically a geological era. Rumors were swirling at conferences, global policies were being updated for years, while the absolute largest trial in human history just sat there, quietly unpublished. Having a trial that exists only in rumor severely distorts the evidence base, creating this massive, awkward, methodological black hole. So when it finally dropped in the Lancet in 2013, the results were a total shock to the system. Remember that 23% magic bullet? Well, DEVTA found that mass vitamin A supplementation led to a mortality reduction of only about 4%. And crucially, that 4% wasn't even statistically significant. Richard Peto was characteristically blunt about it. He pointed out that if you looked strictly at trials conducted in a modern context, the effect was uncertain at best. Based on this 4% finding, he flat out suggested it was time to seriously reconsider continuing these massive mass supplementation campaigns. Chapter 3. The Scientific Backlash. As you might guess, the response was an immediate and ferocious counterattack. Johns Hopkins researchers, who had been instrumental in those earlier foundational trials, stepped right up to rigorously defend the old paradigm with intense methodological critiques. Let's walk through their arguments neutrally, because they raise great points. First off, DEVTA's control group had an unusually low mortality rate, meaning the trial might have actually lacked the mathematical power to prove anything meaningful. Second, DEVTA only had 86% dosing adherence, whereas the older trials were highly supervised. And third, they pointed to the design effect of randomizing massive clusters of children all at once, rather than individuals, which statistically weakened the data even with 1 million kids enrolled. So the crucial point we are dealing with here is really a debate over what we are actually trying to measure: efficacy versus effectiveness. The older trials measured efficacy. DEVTA, on the other hand, with its realistic 86% adherence, might have simply measured effectiveness. Both are totally valid, but they answer fundamentally different questions. It's exactly like the difference between testing a car's top speed on a perfectly paved closed track versus testing it in messy stop-and-go city traffic. Does a perfectly delivered capsule save lives, or does a messy real-world government campaign save lives? This methodological debate quickly bled into a deeply moral one. I mean, put yourself in the shoes of a global policymaker for a second. Do you withdraw vitamin A based on one single new trial and risk causing children to die because you jumped the gun? Or do you keep blindly funding an ineffective program based on outdated evidence, which drains scarce resources away from interventions that actually work today? The fascinating thing is, both sides were completely rational here. They were just terrified of making a different kind of mistake. They were essentially making different methodological bets on which statistical error is morally worse to commit. Chapter 4: The Uncomfortable Truth. Let's move to 2017 and see how this builds. Because the Cochrane collaboration, which is widely considered the neutral umpire of global health evidence, stepped in to try and finally settle the war. They pooled the new DEVTA data alongside the historical data and landed on this awkward middle ground, a 12% pooled mortality reduction. But honestly, this average is dangerously misleading. The Cochrane authors explicitly noted that this 12% was driven almost entirely by the older pre-1990 trials. When they looked only at the modern trials, the benefit practically vanished. See, pooling data from 1986 and 2013 assumes the background context is exactly the same, but it wasn't. The pooled estimate summarized a world that simply no longer exists. Which brings up a really fascinating ethical question. Was it even fair to deny vitamin A to the control group in the DVT trial in the first place? Well, the answer depends entirely on when you ask. This is the concept of dynamic equipoise. When DVT began, genuine uncertainty existed in the scientific community. Over time, as Hopkins researchers became more convinced of the benefits, that uncertainty eroded. But once DVT actually published its 4% finding, bam, uncertainty returned. What is considered ethically appropriate isn't some static rule. It constantly shifts as evidence evolves over decades. Chapter 5: When Science Outgrows Trials. You know, the original 23% evidence was likely completely right for its time, but this whole saga reveals the massive danger of what political scientists call policy lock-in. Once a huge global health intervention is institutionalized, once the supply chains are built and the multi-million-dollar budgets are set, it becomes extraordinarily difficult to dismantle, even if the underlying evidence starts to erode. Which brings us to the 2024 WHO guidelines, representing a very careful compromise. They now recommend mass supplementation should continue only where deficiency remains severe, over 20%, but the country should actively consider phasing it out as everyday food fortification scales up. More importantly, we just have to accept that we cannot do another million-child DEVTA trial. Modern methodology has to adapt using observational data and models, rather than waiting around for another perfect trial. The vitamin A wars weren't just a narrow debate about a single supplement. They revealed the incredible, messy friction that happens between a rapidly developing world and the slow, massive trials we use to measure it. It shows us that scientific certainty isn't always permanent. So I want to leave you with this final thought to ponder. As global health interventions actually succeed in changing the baseline conditions of our world, and the ground shifts beneath our feet faster than our clinical trials can keep up, how do we actually know it still works?